right. I'm Rob Pack, Professor and Associate Dean for Academic Affairs in the College of Public Health. I know many of you, but not all of you, and welcome to Prescription Drug Abuse Grand Rounds. This is the last one of the year. I guess it's our 8th one, and we've been doing this, 8th or 9th. We've been doing it for about 2 years. The purpose of this gathering is to get people up to speed on evidence and some of the current research topics on prescription drug abuse. We do this as part of our NIDA-funded research and infrastructure grant called DIDARP. DIDARP stands for Diversity Promoting Institutions Drug Abuse Research Program. So we'll tell you all about that today. Today is actually an update about DIDARP, the thing that funds us. We'll be going through a bunch of slides, but pretty quickly. So you might get bored, but I hope not. So the second presenter here is Nick Hagermeyer, but I'm going to take care of his slides today. Nick was traveling to Indiana, and I was like, I can do this, man. I've got your slides, so don't worry about it. And so he's on the road. And then the third presenter is Billy Brooks, and he'll introduce himself whenever he comes up. But briefly, Billy's a dissertation writing doctor of public health candidate in epidemiology. Let's see if this thing works here. It worked a moment ago. All right. All right. Not working now. Okay, I'll just stand back here for a few minutes so I can figure this out. So, why are we studying prescription drug abuse? Well, nothing's working. Hold on a second. Maybe that was it. Here we go. So why are we studying prescription drug abuse? And what do we mean when we talk about prescription drug abuse? Well, what we're talking about is actually a lot of opiate products, like hydrocodone, oxycodone, right? And we're also talking about abuse of other Schedule IV narcotics, like or Schedule IV drugs like benzodiazepine. This one happens to be Xanax, and in the Controlled Substances Monitoring Database in 2012, these are the top 10 drug types: hydrocodone, alprazolam, oxycodone, and on down the list. So these are the drugs of abuse, if you will, drugs on which you can become dependent. Turns out that in the world, we've got the biggest problem with this opiate use and even misuse. We have the biggest problem by far compared to other countries. And in this country of greatest misuse and use, we're actually the number 2 state. So, and in this state, the number 2 state, which is only number 2 by probably a rounding error, right? East Tennessee is far and away the worst region in this state. So we're sort of in the epicenter of this problem. There are very few talks I give on this where folks in the audience are not personally affected by this, either in their home, themselves, friends and family. They're very close to them. This massive amount of opiate use and concomitant misuse has resulted in a pretty tight correlation between, well, sales of opiates, which has really risen sharply since the late 90s, treatment admissions for opiates, right, per 10,000, and then overdose deaths. Overdose deaths have recently plateaued, in particular overdose deaths resulting from prescription opiates, but heroin overdose deaths have tripled because of the replacement, if you will, as we have begun clamping down on prescribed opiates. So in Tennessee, we think about 5% of the population, a little less than that, has either an early intervention level problem with this or a needs treatment now kind of problem. You can see the numbers there, pretty staggering numbers that leads to a lot of costs. You might imagine there are huge costs to hospital systems and others for this this particular condition. And one of the major costs that we're seeing is babies that are being born addicted or rather dependent on narcotics. And I guess in late 2013 is the last time this slide was updated, but last year this number was over 900. We had in Tennessee over 900 babies born dependent or withdrawing, if you will, from opiate narcotics in Tennessee. Turns out that in Tennessee we also, at around the same time, had the highest, greatest portion of that here in Northeast Tennessee, in Northeast region and in Sullivan County. Children are otherwise, the children that are growing up that are not infants are also impacted by drug abuse. You can see here what the statistics are and resulting child abuse from substance abuse. And if your cars have been broken into, your house has been broken into, or whatever around here, pretty good chance it was a result of drug crime, which has doubled in the past 10 years. I mentioned this earlier briefly, but we're seeing a pretty tremendous rise in heroin at this point, and in particular heroin overdoses. And part of that is because what's happening is we're beginning to clamp down on the amount of pills that are being prescribed to folks, and beginning to turn that down a notch. And then what's happening is folks in the community are finding other sources of opiates, and they're kind of easier to get at that point. This is a complex problem. Many of you have seen this slide before, but it's sort of our paradigm for how we think about it here. This is non-use over here, and this is sort of at the end of misuse. You can imagine a particularly negative outcome. And so in the middle is sort of the dependent space, and then past dependence is addiction, where one behaves very compulsively to obtain their narcotics. We think that this, is really sort of the danger zone, high danger zone right in here. This is, you can probably get somebody back out of a dependent state a little easier than you can down here, and so on. The boxes around the outside edge of this are really just pointing out the fact that you can't assume that any one intervention is going to fix this, because any one intervention for which we have good evidence is actually only hitting one point along the continuum. So what needs to happen with this is we need to push a lot of pieces forward to address the problem. We need to be taking really good evidence-based programs from the National Registry of Evidence-Based Programs and Practices, or the Community Guide, or things that have been proven to work. We need to figure out how to scale them up. We also need to really enhance our controlled substance monitoring database, and in particular, make them interoperable with surrounding states. We touched 7 states in Tennessee, so we got a real problem there. We need to get away from this uninformed opinion about medically assisted treatment. There's a massive reaction culturally that folks have to things like methadone and Suboxone and buprenorphine. We have to address that, but we also have to be responsible in how we use this, because frankly, there are some pretty shady providers. Okay. We have a new. We saw a talk recently about naloxone, or the ability to reverse an overdose event with naloxone from Project Lazarus, and that is something that's being done and propagated. But frankly, since it's all the way down here at this end of the continuum, it's literally bringing somebody back from the couch, from an overdose state on the couch. Project Lazarus, if you will, right? It's what it's named after, bringing somebody back from the dead. Right? It's a failure of prevention. It's a failure of public health. So while it's necessary, it's also, something that I would prefer not to have to promote. We have good evidence for drug courts, but we need to be doing something better with treatment of mothers. Screening, brief intervention, and referral treatment is a subject for under ongoing study and evaluation. Is something that we're really trying to engage with here. and we have to do a better job with health professions. So it's a complex problem. There are a lot of interventions. We have to bring them all forward, and that's kind of our perspective here. So what's being done about it? The governor's taking this very seriously. He signed the Controlled Substances Monitoring Database Act in 2012, and that's really made a pretty significant difference. We do have a statewide prescription for success from the Tennessee Department of Mental Health and Substance Abuse Services. They've been here, in fact, to talk about this plan. Those are a lot of policy level initiatives, and we're thinking a little bit differently about some of the things, but we're working in accord with their recommendations. So, getting us to the matter at hand, about 3 years ago, I guess, a number of us began thinking, what can we do here to really scale up our efforts to address the problem? And so we began meeting around now, I guess, maybe in March of 2012, and we've been meeting since then. I don't think we've even canceled any meetings. It was it's been one of those things that it began to gather some steam, and so the purpose of it, the purpose of the working group is what we called it, was to sit down together and figure out what assets do we have, to really think out loud, to brainstorm, and to set aside time to do that. Not just to have a driven agenda but it's actually, can we get to know each other, what our strengths are, and figure out how we operate together in a way that will maximize everybody's impact. And so it's been growing. We now have over 100 people on the email list. We get 25 to 30 is a large number, but we probably get around 25 or so every month. Highly interprofessional. We talk about research there. We also talk about community outreach, education. We try to get into this, engage with this concept of systems thinking, which Dr. Baker and Billy and others have begun really helping us think through. And the concept is, how do we take this and scale it up? This is a thanks to Sarah Warfield for this. Sarah put together. She kind of went through the list and said, "Hey, where are all these people?" And that's sort of the representation of where they all are, in either the university or from around the community. We have coalition representatives. We have a whole bunch of health sciences, faculty and students and others. So this is a little bit of a busy slide. I'm going to take you through it for just a second. Over 100 members. Green represents either funded or active. Red represents not funded, doggone it. And then blue is under review, and this one was under review until this week, and we got our score, and it wasn't very favorable. So I'll tell you about that in a second. So we did sort of out of the working group, we wrote a proposal that was funded for 5 years. Then we also got a state-funded NAS grant. Began working with some folks on NAS outcomes up in clinical rehabilitative health sciences. Carrie Proctor-Williams, she's got an RDC, I think, funded here. Angie has been spearheading efforts to get folks over in Carter County engaged with a coalition. It's one of our few counties that didn't, one of the counties around here that didn't have a coalition, and that's been really, actually, very, very rewarding. Began working in this government and workforce space thanks to Katie's involvement on the commission. We just made some inroads to a couple of key offices, and all of a sudden we were best friends with the mayor of the county, and he has us coming to the First Tennessee Development District. Is that right?
Yes.
Yeah, First Tennessee Development District. And we spoke to all the elected officials in Northeast Tennessee, gave them about a 3-hour in-service, if you will, on this topic. They got highly engaged with the concept, and he's wanting to be kind of a leader in this, and so he's got us coming to the county commission, and we're engaging now with some activities related to drug-free workplaces, and in particular, evidence-based programs are effective for promotion of drug-free workplaces, not just drug testing. So there's some other activities there. So our stimuli grant is not going to be funded. Our impact score was 68. which is not good. So we'll break that apart and begin looking at some other items, I think, in that. We do have a TVR grant under review. We also have an RDC under review through Raj. And we did put together a PRC proposal, but that was a bit of a long shot given the CDC's orientation toward this problem is really on the injury side or the overdose side. So we've got a lot of different products, and that's just part of them. That was just for the flavor. I mean, there's a lot of other activities and engagement with folks out in the community. This just kind of gives you an idea of what some of the volume is. A bunch of papers forthcoming. This was done a while ago. I think there's one or two more after that. Most of which are driven by this guy and this guy. This is Nick Hagemeyer, who's over in pharmacy, and Jeff Gray is part of our team, and of course Raj is PharmD PhD actually, and an expert in stimulant misuse. Fred Tutteber from medicine. A bunch of grad students and fellows. We've got Dan Vincentelli's PharmD's back here in the middle, and then we have other students. Stephanie and Sarah, of course, our Sham's the co-investigator, and there's Mr. Brooks right there. This is our director, Angie Hageman, and that's about the whole team right now. So DIDARP, what is DIDARP? DIDARP is a infrastructure development and research grant. Okay, so within DIDARP, there are 5 aims. And then inside of those aims, really, frankly, there's really more like 5 overarching program aims. Then there are 3 research projects inside. Okay, so we'll go over the aims, and then we'll get into some data. So the first one is to provide leadership and support within the Academic Health Sciences Center to increase the number of prescription drug abuse researchers from disadvantaged backgrounds. And this is broadly defined. We qualified for this award through the volume of students at the university that are Pell Grant eligible, which is a lot. I forgot the exact number, but I think it's 50-something% at this point. So it was a lot, and we exceeded the metric by 2 times. So we have a bunch of folks that are engaged with this, and the purpose is to help grow the institutional infrastructure so that people will go into prescription drug abuse or drug abuse research. Second aim is to provide mentored training opportunities for undergrad, graduate, and professional students, postgraduate fellows, and junior faculty that increase the likelihood of pursuing prescription drug abuse research careers. So some examples of this, we have mentoring meetings. We also are engaging people on the National Postdoctoral Association core standards, kind of their sort of research skill based metrics, and we have a couple of students that are going to NIDA. Stephanie, for example, and Sarah are both going to NIDA in a couple of weeks to engage with a 2 or 3 day workshop on how to write proposals and so on. So things like that is the second aim, purpose. Third aim is to develop institutional infrastructure to support successful conduction of research, prescription drug abuse research, and attract external funding for this topic. Of course, have the working group. We've done some work with respect to strategic planning for the research. I'm personally engaged with that, and so are some others on the team, including Nick. This is old. We got more like 9 or 10 new research proposal submissions at this point. And we'd love to get a center for prescription drug abuse research and prevention and treatment here. And this is the center concept. We're going to move on right now. There's the proposal submissions, kind of went through that a little bit already. The fourth aim is to advance the field of prescription drug abuse prevention research using these resources and the studies. And of course, creating new knowledge as well as kind of enhancing practice in the region. One of the things that we've been able to do is put together a website. Thank you, Rahul, for all your work on that. We have a lot of resources on the website that folks in the community can access, including this work basically, this is how we engaged with the First Tennessee Development District, and we put together a whole lot of resources about using local data to give counties their own current profile, as well as we tried to inventory all the prevention and treatment resources in every county in the Northeast Tennessee region. This was spearheaded by Billy and Ikra and Sarah, I think. Is that right? We have a number of, I guess we have at least 3 manuscripts under review right now. This one's been accepted. Our first DIDARP publication will actually be a drug Dropbox study that Jeff and some of his co-investigators have put together, and it's been accepted in American Journal of Public Health. We have this one under review at, it's about the working group specifically. Jerry Ann has this one under review, and we have others. But so many presentations, I don't even know how many at this point. And then our 5th aim is to evaluate the effectiveness of all these activities and to disseminate the findings, and then conduct the research projects. And so I do want to mention that we think that this is serving to have a regional public health impact. We think it's growing the awareness about the problem in the region, and the partnerships that we're developing are beginning to create a pretty good web and network of parties that can get engaged with places on that whole continuum where we can have a pretty tremendous impact. I'm going to go quickly into a couple of studies that are ongoing inside the DIDARP work. The first one is DIDARP Project 1. This is what Nick would have been presenting on. This is healthcare provider communication and prescription drug abuse and misuse. So basically, well, I'll take you through. So our objectives here are to describe the role of communication in prescription drug abuse prevention and treatment, and then describe the outcomes of 5 focus group activities that were conducted in the SATNet region. These are not the objectives of the research. This is part of aim 1, okay? And I think that there are 3 aims in that work. It's just qualitative work on the front end. I mentioned that we have a massive amount of prescribing going on here. So the number of painkiller prescriptions per 100 people. These are the states in the highest bottom, if you will. You can see Alabama's highest there, second highest. This is 2014 data, and it's published, actually this says it's in 2012, but this data is very consistent with the 2014 data that came out in the MMWR on July 4th of 2014. Look at the disparity here. This is can you guys read that? 143, basically, painkiller prescriptions per 100 people. That's 1.4 scripts per person per year for painkillers. And, that's really more than twice as many as in New Jersey and New York. And in the lowest state, Hawaii, almost 3 times, well, not almost 3, 2.5 times at least. Oh, goodness. Oh, there we go. So the ONDCP's Office of National Drug Control Policy, they list communication as being a very important area for research and study. So they're also particularly interested in education with parents, with youth, with patients, and healthcare providers. This response to the epidemic came out in 2011. Also talks about monitoring, disposal, which is another area of study of ours, and enforcement. Communication is one of the key constructs that they put forward, and of course what we began studying here. So many doctors aren't properly trained on screening for substance abuse and how to intervene, so they feel very uncomfortable asking patients about drug and alcohol abuse. It turns out that they also are uncomfortable asking each other about their prescribing habits and also their dispensing habits. Our model is really that we have a triadic situation happening here where the patient is maybe having some poor communication here and here, right, and really doesn't know what's going on here or even how to lock up their pills or whatever. And all of this is influenced by health communication and interpersonal communication constructs like perceived communication competency, willingness to communicate, communication avoidance, and things of that nature. It's theoretical, it's theory-based. So one of the things that we hope to do is just talk to you about progress up to today. We have done a lot of focus groups with Project One within the AppNet region, and then we've got the transcripts from them, and they're undergoing thematic analysis right now. Just a little bit about the emerging themes for healthcare providers, communicative factors, and this one is hard evidence is called. I think the first thing you do is you pull a database and do a drug screen, pull a drug screen, do the screen, and see if they fall out. Because a lot of times they'll fall out, and then that takes care of your problems. You got hard evidence on the drug screen, on the UDS, okay? That's one of the communication factors. And then that takes care of your problem. You don't really have to deal with it after that. Well, the second one is practice barriers. In the healthcare provider's practice, they have a lack of time, a lack of resources. So if all you had to do, if you had time to do all of this, you'd be broke. That's another way of saying it. Because basically, you're not taking care of patients if you're doing all this. And billing is what happens when you take care of patients. So you give them 15, 20 minutes per patient. So when you're looking at controlled substance on top of hypertension, diabetes, and this and that, another thing becomes a problem in trying to address everything you're supposed to do. Sometimes they do well, they even go out of the room to check the CSMD. And then with respect to individual policies and procedures, he's talking about, in this case, this provider is talking about regarding drug seekers. My behavior is I just tell them I don't have the pills. I just tell them I don't have them. And these folks are talking about likability and patient satisfaction. One of the things that we believe contributes to this is this concept of hospitals being scored and doctors being scored with respect to the interactions with the patient and how satisfied the patient is with that interaction. So we think that may be an underlying contributor that's helping to drive this, and in particular the fear that they may be downgraded and the hospital may come under some sort of scrutiny for accreditation. That appears to be an underlying driver for this whole problem. I think that's one of the elements that contributed to the perfect storm that we've seen in terms of great rise in prescribed opiates. With respect to pharmacists, they lack information and trust. This particular person doesn't like the people, doesn't like the feeling that he gets from them, and just particularly people who are abusers. But some of them, they're scary. They're abusing drugs. They just kind of, I legitimately feel I don't do anything illegal. He looks like he's a little bit conflicted there. But difficult or uncomfortable conversations are avoided. Communication avoidance is one of the constructs that we're talking about. Be direct, and I'll say, well, I don't know you, and I don't prescribe these medications on the first visit. Really, this is avoidance right here. I don't prescribe these medications on the first visit. If I see you for a couple of times, I think you need them, I might prescribe them, but there's a good chance I might not. Some of our other work has been in the area of perceptions of legitimacy. It turns out that pharmacists very often feel like only about 60% of the people that come in with pain scripts are actually legitimate. That's what the pharmacists feel, and doctors feel that they're hitting the nail on the head much more, and pharmacists feel like maybe not. And there's pretty big discrepancy between how legitimate the doctors think the patient is versus the pharmacists. So what we've learned? Well, we've learned that prescription drug abuse communicated behavior is extremely situational, that the subjectivity invites simplification and sort of like just kind of getting it done and getting it over with. And the dissonance exists between the patient care model and some current business models. Think about what's going on in the pharmacy. Often, there's not a private place for communication, or really taking the patient through their medications, and it's as if the literature that's prescribed or stapled onto the bag is going to be good enough. But frankly, the health literacy of a lot of patients is super low, so that can be an issue. And if you think about the business models, I mean, their volume is remunerated here, right? Not really health. And so we have a lot of people coming in and go through the system, and the business model can be a little bit challenging to do a lot of good counseling in. And then there's a perception that non-confrontational communication is actually, rather, perceived non-confrontational communication is actually confrontational. And so there's, I think that there's a feeling by a lot of folks that if I say anything about this, then it's going to get really ugly. And so they just kind of avoid it. Nick threw in this cartoon. So your medicine fell down the sink, huh? And just your pain pills, not your blood pressure meds. Yeah. So this interprofessional communication, this interpersonal communication, and this communication between the physician and the pharmacist and the patient, that kind of sets up the second study, which is Project 2. Patient-provider, these are dispensers and prescribers, communication to prevent prescription drug abuse. On this particular research study, I'm the PI, and Nick and Arsham are the co-Is. This one in Project 1, I should have mentioned earlier, are 5-year projects for the duration, and they involve qualitative work up front, and then both of them will have full-scale surveys with appropriate power and study designs for the techniques that we're using. So Project 2, we haven't gotten into the analysis yet, so I'm just going to kind of tell you where we are with respect to the data collection. We've done 20 health professional interviews. These are open-ended, semi-structured, audio taped, and then transcribed. We're asked about the communication apprehension, willingness to communicate scales, self-perceived communication instruments, as well as our dependent variable that we're hoping to put together, or that we've put together, and we're kind of testing out a little bit in this qualitative surveys. And that's particularly about communication avoidance and the history of that. Then we have an ongoing set of patient interviews. In fact, I think we're going to finish those up on Monday and Tuesday this week, this coming week, over in Jellicoe and La Follette and Campbell County. These are open-ended, semi-structured. We're also talking about these instruments, but as well about other things. We have a variety of people here that have a history with substance abuse, that don't, and that have family and so on. And then the next steps are really, finishing out the transcription and then getting the analysis done. We're using in vivo software, and then after that, we're taking those findings and we're putting them in through the survey informing process. We have some baseline instruments, get some feedback about those, but then that'll also help us identify new questions to ask and what we're going to do in our quantitative surveys. We have a great opportunity to be speaking to a lot of patients, surveying a lot of patients, a lot of providers, a lot of dispensers, prescribers and dispensers. So those are projects 1 and 2. Project 3, I want to let Billy take over, and here's the desk.
All right, thanks, Dr. Pack. So, my name is Billy Brooks. For those of you who don't know me, I'm the goofy kid that was on the flyer. You guys saw that? It's a really creepy picture. I expect a bigger laugh than that. Anyways, did you see the picture on the flyer? It's like from my first year at the RPH. It's just a plaid shirt, big goofy smile. Anyway, so I am a DRPH candidate in the bio and epi department here at the college. I've had the pleasure to work with the DIDARP team and the prescription drug abuse working group for the last couple of years, and it's been extremely fruitful for me. I think my dissertation work was highly influenced by working with the team and so forth. So Dr. Gray, this is really his baby. He's not here today. He has clinic on Friday. So a lot of the work that I was able to do was on the front end as he was collecting his data, and then after we got everything collected, I did a lot of analyses on it. So he felt that was an appropriate choice to present this information. Project 3 is really an attempt to scratch the surface at an incredibly important question regarding prescription drug abuse. It has to do with the access and our disposal behavior and methods for offering those behaviors. So, I had it faced the wrong way. There we go. Okay. So this is one of my favorite figures. I believe it was co-opted from John Dreisner, one of his presentations.
Co-opted, this is actually saying ripped off.
Yeah, ripped off. But basically, you know, if we look at non-medical prescription drug use prevalence here in the center, there are some ways that we can shrink that prevalence, and one is really sort of the supply side, which is sort of what Project 3 focuses on, is access to these drugs that are, you know, have abuse potential. And so Dr. Pack showed you this figure, and this is really where we're at here, working on diversion control, right? Reducing the access, reducing the sheer number of pills that are in the community. But what we're wanting to do, and like I said, is scratching the surface on this research, is we're asking a very basic question. We want to describe what is really being brought in through these donation practices in regards to controlled substances. Because right now, the numbers that you get really are all of the donations, the pounds of, you know, the over-the-counter drugs, all these things that we're really not that concerned with. We're concerned with the drugs that have the abuse potential. So that's sort of what we tried to get at. And you'll see that it was incredibly labor intensive and prohibitive, which is why this is really some of the first research done in this area. So we saw this figure already, but this is really the driver, right? We have this sort of ecological association coming out. We're seeing our mortality rates and our treatment admissions trending along with our prescribing rates. So what does that look like, you know, with regard to the influence of abuse from the access to these drugs? We know that most people report, and many of you have probably seen this, but report that, you know, those reporting past year non-medical use of a painkiller got their most recent drug of choice from a friend or family member. And what's most significant is that friend or family member basically got it from a single doctor. So, you know, diversion control tactics such as the CSMD really sort of focus on this idea of doctor shopping, which is really your high-risk group and represents a small percentage, but actually represents a large percentage of your mortality. However, most people who abuse these substances are just getting it because of access. So someone has a legitimate prescription, it's in the cabinet, they didn't take it all, it's still there, and somebody gets it and gets diverted. So our objective was to basically compare sort of the effectiveness of these reoccurring take-back events alongside consistently available donation boxes. We wanted to look at donor tendencies with regard to, you know, how long folks are tending to keep these drugs in their cabinets prior to donation. We have some population information that we applied to the data, and then there was a promotional campaign that was implemented, and we have data pre and post to sort of assess its impact on our total donations. So it's a real shame that Dr. Gray isn't here to present this information, because he really did a ton of work on the front end before he was paid to do so. So he fostered relationships with DEA, local law enforcement, which were integral to this process, because it essentially allowed us to come in and count these pills, you know, thousands of dollars worth of, you know, controlled substances, and we're in a room just counting. So we did some on-site donor survey for the live takebacks. We have some demographic information which is relevant to our promotional campaign and other things. The process itself, like I said, was really labor intensive. We basically had to sort and count all of these drugs. it consisted really, the research took place over the course of, 30 months in total, including the amnesty boxes, but 18 months for the live take-backs. We had 3 events at 5 different locations, so 15 events in total, and then 8 locations for our amnesty boxes. So the data we collected is really sort of the really impressive part about all this, I think, is that, you know, we had total data for, or total weight for the donations. We had total weight for the controlled substances, right? So let's just stop for a second and think about that, right? So when we go into the law enforcement agency, they've got the drugs laid out in these 50-gallon barrels. We basically dig through them and identify each pill and set it aside, count them all, and then weigh them. So, I mean, you can see why, you know, most places aren't able to do this work because it's, you know, so most of our team is here. Let's show hands. Who's participated in one of these events? Right. Who's super excited to do it again?
I want to say something here, please. So after the first or second one of these, Jeff called me up and he's like, "Do we have some money where we can buy a pill counter, like a really good pill counter?" And so that's one of the things we did. Was after they were sort of segmented by controlled or not controlled, sort of what they were, and we could identify those. Then we could take the controlled ones and then drop them to the pill counter. And it was, and we had to buy one and send it back, and it didn't work well enough, and we had to get another. So we had a really good pill counter.
So one of the other things that we have is the data dispensing, which is a really unique data point. We're able to essentially estimate sort of averages and maybe some differences in different active ingredients with regard to how long folks tend to keep these drugs in the cabinet before they donate, right? And then we have some population information, like I said before. So the live take-back collections, this is a picture of one of the events. For some reason, is that you?
No. No, but I will say this. One of the great things about this is getting the pharmacy students and the public health students engaged with it. That type of work, that level of workforce, makes this thing go much quicker, and it's entertaining as well.
Yeah, everybody's pretty enthusiastic. So over the course of these 15 live takebacks, we collected 35,000, almost 36,000 total units of controlled substances, and you can see that the distribution is such, that 3-to-1 opioids, right? And one of the things that I'd like to impress upon you in this presentation is that all of the data that we've collected, all the results that we've generated, really sort of lead to our next project proposals, right? So the question now with this data is, how does this relate to the CSMD data that we might get that we, as yet, don't have access to? Nobody really has access to. How does that relate to our donations? So what percentage of what's prescribed in these areas is really being used, what's being donated, and so forth? So this is really sort of a look at what is represented in our total donations by controlled substances. For the takebacks, it's about 5%, which is really important. I can tell you, I work as an evaluator for a Drug-Free Communities grant in Transylvania County, and one of the things that is really easy to jump on is education with regard to these donation boxes, right? So we really need to understand. The first step is a descriptive analysis of what's really going on with the donation boxes. And that's what this is really giving us here. It's a picture of that. And so we look at sort of the total units collected from the different sites. Bristol, it's a big city. It's not the biggest in the sample. Johnson City's bigger, right? And so we apply a population denominator to that, and we see our per capita really change. The distribution changes quite a bit. And again, this is research generating, right? Because this is, we don't know what the mechanism is at play here. Blountville has been talked about as sort of has a lot of through traffic, and we do know that there's a big, research has shown that there's an effect of potential or likelihood of donation to these boxes given distance. So I think it's a 5-mile radius that the likelihood that someone's going to donate in these boxes really goes down. Right? So, again, hypothesis generating here. So the Amnesty Box collections, this is one of the boxes. We call them Amnesty Boxes because they're totally anonymous, and you can drop anything in there. I mean, I think anything, right? So if you, I'm not sure how it would work if you had a bag of dope and you wanted to go to the police station and drop it in the box, if they saw you before you dropped it, or like how close to the box you had to be. But at any rate, it's anonymous. They don't ask any questions, and we found crack in one of the boxes, and everybody in the room was like, "Holy crap, that's crack!" Because nobody had seen it.
And marijuana?
Yeah, tons of marijuana. Yeah. Of course, we think that the cops may have been putting it in there so they didn't have to write up the paperwork. But anyway, that's neither here nor there. So again, the distribution is very similar here, and for these, for this method, we collected 135,000 pills now, or units. That includes milliliters as well. This was over 30 months, right? The take-backs were over 18 months. Very relevant. You know, we have to really consider not only for the total time interval, but for each site too, and I'll get into that. But again, you know, what is the relationship to the CSMD, and also some other questions that I think Raj and some other folks are asking. We'll talk about in a second. Similar distribution here. About 5% of the total donations were controlled substances. And again, you know, so this is interesting here. This is one of the things, I actually had to go back and look at this morning. So Bristol is one of our larger cities. It's like the third largest, I think. And it's really not showing much here. And it turns out we only had four times Jeff went to collect, and it was really only over the course of about 380 days, right? So just at a year. And you know, Kingsport, for instance, we've been collecting since 2012. So these comparisons are really not very appropriate, right? So we do it per capita. We add the population to it. Again, Bloomville jumps out, Jonesboro as well. But then, so we apply the time component to it, and we look at basically the average monthly donation per 1,000 in units and in weight. So in red is the pounds, and in blue is the units, and we're seeing this really like distinct and frankly suspicious bifurcated distribution here, where again we don't know what's at play, but we're seeing the municipalities where populations under 2,000 is significantly higher than those with the larger. Now, there could be some effect of, you know, if it's a more rural area, for instance, Mountain City. You know, if we take the municipal population and use that as our denominator, what we're really capturing in the sample is folks that live outside of the city limits of Mountain City, because it's a more rural area. This is something that we've been thinking about. But again, we think that this is hypothesis generating, right? So we are now we can start to think about ways to test this, and you know, so what is in fact at play here? So if we look at Amnesty Box donations against take-back donations over the same time period, so we've hit the same interval, right? You know, what does it look like with regard to where we collected more controlled substances? And we can see in most of these collection sites, and in the average, we're over the Amnesty Boxes we collected more than we did in the take-backs. And I believe this is something that Raj is looking into, right? So, you know, we're arguably sampling from the same population. So, what is in fact the effect of, you know, donating or donation levels for one on the other, right? Because, you know, there's going to be a finite amount of drugs in the population. So, the other thing is we had our dispensing dates. And so the data were quite skewed, so we'll just focus here on the medians. And in fact, you know, I would argue for not really paying a whole lot of attention to the miscellaneous category, because it's really sort of a catch-all. We've got testosterone and all sorts of different drugs in that category, and you can see it's terribly skewed here. Opioids remained in the cabinet longer, tended to remain in the cabinet longer than any of the other drug classes. So, you know, my theory is that they're more coveted, for instance, that they're harder to get. Like if we're changing the schedule on some of these drugs, which happened, I think, for hydrocodone last year, you know, it's becoming evident to folks who have these drugs that they may not be able to get them again, so perhaps they're holding on to them longer.
for sort of a rainy day.
Right. For
Yeah.
exactly.
Or the injury that could happen where you might not go to the doctor or something like that. I think that's where people are holding on to.
But we don't have any individual level data with regard to demographics or any sort of possible covariates. So that would be a next step, is that if we're able to somehow get some information on folks who donate and tie it directly to their drugs that they donate, which is tough because it's got to be enough. So the media coverage, this is really quite impressive. I don't really know a lot about exactly what the coverage was. This is really Dr. Gray just did this and he headed it out and hired a consultant and really high quality stuff. I'll go ahead and show you actually a couple of these. Yeah, I think they're good. Well, okay.
This
Next one.
it's David Road.
They're all having such a good time donating their pills. I think it sends a really good message. All right. So that's one that has to do with our drop boxes, and then this one, the next one is a little heavier, sort of gives people some insight into the effects of. And finally, my personal favorite, probably because of the music. I think these are really good. It's just so soothing. So I guess the point here is that there was some thought put into these things, and they're really high quality. So great product, I think, from the DIDARP work. I don't know if you wanted to say. I really don't know what the campaign itself, like what the breadth was of it, but we do have some sort of preliminary data. With regard to the possible impact of this campaign on our total donations. So pre and post, this is sort of the pre-weight of drugs that we collected, and then this is the post. For sort of an overall increase of close to 40%. There's a fair amount of variation here. You can see Bristol really drops here, and there's some variables at play that we're not really clear on. So future work would really sort of expand this out to some more years and diverse population and so forth. So we learned some things about the types of drugs, and so the opiates obviously the most donated. Like I said, they were the most coveted is what I'm using, but essentially they tended to stay in the cabinet longer prior to donation. The embassy box donations outpaced live take-back donations, and however, the controlled substance percentage by weight is similar. And I think this is encouraging because I don't know how, one of the things that would be ideal and how possible it is really sort of requires a ton of work, I think, is if we could provide a template for estimating the controlled substance donation by total donation across diverse populations, then this work wouldn't have to be done continually, right? But you'd have to do a ton of research and again, apply this type of work across populations. So, and there seems to be an association between population size and per capita donation rates. And I say there seems to be because obviously there's a mechanism in play that is not illuminated through this work. So this is the team, and that's Dr. Gray there. If there are any questions that you guys have that I'm not able to answer, he's one of the nicest guys I've ever met. He would be more than happy to talk to you. So, thank you.
We'll take any questions if you guys have.
I wonder if Bluntville's just an older population or something, because I don't really know. You know how people are around here. You ever go to the thrift store? They don't throw anything away until it's worn out. So I really don't know why people would donate their opioids back unless they were trying to keep it away from their kids or their grandkids.
Could have something to do with Bluntville's county's nature. There may be more governmental offices there, and so the take back, not take back, but the drop boxes are more known.
Yeah.
It's really not a huge population in Bluntville, and so that could be another thing. Just give them a relatively small number of folks plus the number of governmental workers that work there. It could be something like that. The interesting thing to me is this 10,000. That kind of bifurcation of the larger cities and the smaller cities, and what's going on there. It's not totally clear what's up. And it could be that all of those little cities have something in common, and there's nothing going on here other than that. But we'll have to kind of think about some more, play it out, and see what's going on. This work. So the first question I think about something like this is, how do you know what your impact of your media is if you have a geographic space that doesn't have any control, right? And particularly when you have all these towns where everything kind of overlaps a little bit. And the answer is, the only way to do that is really to do a control study with a physically distant location, and it doesn't have any media contamination, and follow the same kind of things. And we didn't have that funding for this particular study, but it's something that we could pursue in the future. Another thing that's interesting about this is, so the drop boxes are sitting there and they're accumulating pills all the time, and or other drugs like crack. Anyway, they're accumulating these all the time, and the take back events are actually just very brief points in time, a couple times a year. Yet the take back events yield almost as many pills as the drop boxes. So that's also interesting. We might want to turn up the take back events 2 or 3 times to see how many more we can get. But the impact of this work is that there's 35 or 36,000 pills that are controlled substances that are not going to be abused, and they're not. And there's kids that don't have that opportunity now. And so I think that if you step back away from this a little bit and think, well, that's a lot of pills. When you see one of these take back one of these take back events, and folks are laying everything out and counting them, and then putting them in 50-gallon cardboard barrels, and the volume is striking. It really is. And some of the stuff that we're seeing, are like hardcore Schedule 2 fentanyls. There are tons and tons of really risky opiates. Risky is the wrong word, but really high value, high street value, and high value in terms of just their
high potency.
High potency, yes, that's what I mean. So it's a pretty amazing volume. And the last thing I want to mention, I'll turn over to Billy, see if he has any comments. the incineration process for these is kind of fascinating. I haven't actually I haven't seen it. But apparently, what happens is they go over to Eastman and drop it in the incinerator, and then before it hits the ground, it's so hot. Before it hits the ground, it's supposed to be incinerated. It's like they told me the temperature was astounding, like almost inconceivable amount of heat. But they drop it in and poof, vanishes. Yeah. The reform is in the air. Across Johnson City. It's collected by the rain. Any other thoughts?
So, I mean, I guess you mentioned that this work, basically as presented here, has been accepted for publication in AJPH, and I think that's a testament to the newness of this research. There's really only, I think we've identified now 3 other studies published that focus on take-back events, and none have the sort of granularity of the data that we have. And you know, I just think this is sort of like the first set of questions to get into.
Yeah. Any other thoughts or questions? Thanks for coming. Did you hit storage?
Just to get rid of it.
Took off half his head. Oh, did it? Yeah. So what happened was the flash, when it hit that oiled up cabinet back there, it had a huge glow around it. And so that's photo editing software that did that. Yeah.
Yeah, he doesn't